Welcome to the deep dive. Today we're jumping into a really important area of pediatric revision material, our focus, meningitis B.
Yeah, it's a big one. We've got a stack of notes here, the kind designed specifically for revision. They give a really structured overview of this critical condition.
And our mission, well, it's pretty simple. Take these notes, unpack them bit by bit, and really pull out the absolute high-yield information you need to feel confident.
Right. Cutting through the complexity, focusing on those essential facts, getting the most sort of bang for your revision buck.
Exactly, because let's be clear, meningitis is serious stuff, and having a solid grasp on it is just vital. So let's dive right into what these notes lay out for us.
Sounds good. Where do we start?
Okay, let's get straight to it. First thing the notes hit us with is, well, the definition. What exactly is meningitis?
Okay. So at its core, meningitis is inflammation of the meninges, those membranes that surround and protect the brain and spinal cord.
Right, the protective layers.
Yeah.
And what causes that inflammation? Is it always like an infection?
Most commonly, yes, it's caused by infection viruses, bacteria, other microorganisms. But it's important to remember the notes mention it can also be due to non-infective factors.
Okay.
Yeah.
I think a really key point highlighted early on is that viral meningitis is actually much more common than bacterial. But any suspected case is managed initially as bacterial. That really speaks volumes about the urgency, doesn't it?
Absolutely. It has to be that way. Given the potential speed and, frankly, the severity of bacterial meningitis, you just have to treat for the worst while you're figuring things out. It's a crucial principle in practice.
Yeah, it makes sense. And when we talk about meningitis B, what specifically does the B refer to?
So that B pinpoints the specific bacterium responsible. Neisseria meningitidis serogroup B. The notes also clarify something important. This bacterium can cause a whole spectrum of disease, which we collectively call meningococcal disease.
Okay.
So about 15% of those cases are just meningitis, maybe 25% are just septicemia, blood poisoning, and then a significant 60% actually present with both.
Wow, 60%.
Yeah. So meningitis B is one, albeit a very important manifestation of that broader meningococcal disease picture.
Got it. Okay, so while our deep dive today is on meningitis B specifically, the notes also broaden out the etiology, the causes of bacterial meningitis more generally, and they break it down helpfully by age group.
Yeah, this is where you really need to tailor your knowledge. It's not one size fits all. For neonates, for newborns, the notes list Group B streptococci, or GBS,
Right.
Listeria monocytogenes, and Escherichia coli. I sometimes think of it as the GLE list for newborns, if that helps.
GLE. Okay, yeah, that's a good way to remember it. And then as we move into infants and older children, what changes?
Well, here the common culprits shift. You start seeing Haemophilus influenza type B, though thankfully much less common now because of the Hybe vaccine.
True.
Neisseria meningitis, including our serogroup B, of course, and Streptococcus pneumonia.
Okay. And then for adults and older folks, or maybe those with weakened immune systems.
Yeah, you'll see S. pneumonia and N. meningitis is still featuring prominently. But you also see gram-negative bacilli cropping up more. And in the elderly or immunocompromised, the notes add Listeria monocytogenes back into the mix.
Ah, Listeria again.
Yeah. Plus other possibilities like TB or other gram-negative organisms. It really highlights how the differential changes depending on the patient in front of you.
Definitely. The notes also dedicate some specific attention to neonatal meningitis. It sounds like maybe a higher stakes scenario.
It really is. Neonates are inherently higher risk. The notes point to risk factors like low birth weight, being premature, maybe a traumatic birth, or maternal infection during pregnancy or delivery.
Right.
And they specifically mention how strategies like giving antibiotics during labor for moms carrying GBS or doing C-sections for maternal HSV infection have reduced the incidence. But importantly, complications can still persist, even if mortality has decreased.
That's a key point. And the notes also touch on something called aseptic meningitis,
Right.
where the CSF looks inflammatory, but the usual bacterial tests are negative.
Right. So this points you away from those common bacteria we just listed. The causes listed here are typically viral, think enteroviruses, mumps, HSV, HIV,
Okay.
but also fungal causes like Cryptococcus or Histoplasma, parasites too, and crucially, don't forget the non-infective causes. They list things like malignant cells in the CSF, certain chemicals or medications causing irritation, and inflammatory conditions like sarcoidosis or autoimmune diseases.
So if a question points towards a non-bacterial cause with those CSF findings, that's the list to consider.
Exactly. That's your differential right there.
Okay, that's a solid overview of who and what can cause it.
Yeah.
Let's narrow back down now to meningitis B and its specific risk factors mentioned in the notes.
Sure. The notes list a few key ones. Close contact with someone who's infected, obviously. Living in crowded settings, a classic example is college dorms. You often hear about outbreaks there. Being immunocompromised for any reason makes you more vulnerable. And crucially, young age. Infants and young children are definitely the most vulnerable group.
And are there other sort of additional risk factors detailed?
Yes, they add a few more general points. Anything that compromises your immune system's ability to fight off infection, things like smoking or underlying medical conditions. Also, individuals undergoing spinal procedures like having an epidural or spinal anesthetic.
Right, creating a potential entry point.
Exactly. And also those with impaired splenic function. So people who've had their spleen removed or those with conditions like sickle cell disease where the spleen doesn't work properly, they're at higher risk. And the notes reiterate that crowding is a specific factor for outbreaks.
Okay, so let's imagine the bacterium gets in, say, to a vulnerable infant in one of those crowded environments. What's the pathophysiology? How does the infection actually progress to cause damage?
The notes describe it pretty clearly. Basically, the bacterium manages to cross into the meninges, into that space around the brain and spinal cord. Once it's there, it triggers a massive inflammatory response.
Okay.
And it's actually that inflammation, the body's own response, that directly damages the brain and spinal cord tissue. So it's an invasion leading to destructive inflammation.
Simple process, but potentially devastating outcome. So when a child comes in looking sick, maybe with some symptoms that could be meningitis, what other conditions do the notes say you need to consider? What's the differential diagnosis?
Yeah, this is where good clinical acumen really comes in. First off, you obviously need to distinguish meningitis B from other types of meningitis, viral, other bacterial causes, fungal, that's step one.
Right.
But the notes list other serious conditions too. Things like non-infectious inflammation of the meninges, maybe an intracranial abscess, which is a collection of pus inside the brain.
Okay.
Encephalitis, that's inflammation of the brain tissue itself, different from meningitis, which is the membranes. A subarachnoid hemorrhage, so bleeding around the brain, or even sometimes a brain tumor. They can all present with some overlapping features, especially early on.
Wow, that really broadens the picture of possibilities you have to try and rule out. Okay, turning to epidemiology. What did the notes tell us about how common meningitis B and bacterial meningitis generally are?
Well, for meningococcal B specifically, the good news is the incidence has dropped quite significantly since the vaccine was introduced. That's a major public health success story.
Definitely.
Overall, for acute bacterial meningitis, the annual incidence is about 1 to 2 cases per 100,000 people in the population.
Okay, 1 to 2 per 100,000. And how does that compare to viral meningitis?
Well, as we touched on earlier, viral is much, much more common. But, and this is the crucial bit the notes starkly remind us of, bacterial meningitis carries a really high mortality rate. That's the critical difference.
Yeah.
They also give the incidence specifically for neonatal meningitis as about 0.3 per 1,000 live births in developed countries.
Those numbers really underline the urgency we talked about earlier, don't they? Yeah. Okay, let's get into the clinical features. What does meningitis B, or meningococcal disease more broadly, actually look and feel like for the patient?
So the notes give us the classic picture first. Fever, a really severe headache, stiff neck, what we call neutral rigidity, sensitivity to light, so photophobia, confusion, or an altered mental state, and sometimes that infamous rash.
Right, the rash. And specifically for invasive meningococcal disease, which includes the septicemia part, are there specific signs for that?
Yes, and this is where you look for those really worrying signs. The rash is key, often described as petechial, which are tiny pinprick spots, or purpuric, like larger bruises. And vitally, it doesn't disappear when you press a glass on it. It's non-blanching.
The glass test, yeah.
Exactly. Other signs include that altered mental state, cold hands and feet, even if they have a fever, headache, maybe neck stiffness, mottled or unusually colored skin, and a slow capillary refill time, so more than 2 seconds when you press on their skin.
Okay.
And the notes make a really, really important point here.
Yeah.
If it's just meningococcal septicemia without the meningitis component, you might not see the neck stiffness or photophobia. So don't wait for those classic meningitis signs if the other red flags for septicemia are there.
That's a critical point for picking it up early. Just fever and a non-blanching rash needs urgent attention. What about the more general meningitis symptoms?
Well, beyond the classic triad, you can see more nonspecific initial symptoms. Things like just fever, headache, vomiting. The more specific signs that develop are the stiff neck, the rash we mentioned, sometimes back rigidity, photophobia, and any focal neurological deficits like a weakness down one side, for example.
It sounds like it could be quite tricky to spot early on, especially maybe in young children who can't tell you they have a headache or a stiff neck.
Absolutely. The notes really emphasize this diagnostic challenge, and they highlight some crucial early features to watch for, particularly in children, that might actually precede the classic signs. Things like leg pain.
Leg pain. Interesting.
Yeah, severe leg pain, cold extremities, those cold hands and feet again, and abnormal skin color changes, like looking very pale or mottled. If you see these, you need to think urgent. Maybe think of the mnemonic cold extremities. O for unusual color, L for leg pain, I for irritability or altered mental state, P for petechiae or rash, and S for stiff neck, though that might be a later sign.
Cold lips. That's quite helpful, actually. How does viral meningitis typically present compared to bacterial, according to the notes?
According to the notes, you often see similar symptoms, but usually they're much less severe. The patient is generally less unwell looking, less toxic.
Okay. But as we said, you can't really bank on that early on, can you? The absolute critical takeaway that's reinforced throughout these notes seems to be that early recognition of bacterial meningitis or meningococcal disease is just non-negotiable for improving outcomes.
Couldn't agree more. It's paramount. Which leads us nicely into investigations. Once you suspect it, how do you go about confirming it based on these notes?
Right. Well, the definitive investigation mentioned, the cornerstone, is the lumbar puncture, or LP, getting a sample of that cerebrospinal fluid, the CSF, for analysis.
Yes, that's absolutely key. Other essential tests listed are blood cultures. You need to check for bacteria in the bloodstream too, and PCR testing on blood and CSF. PCR can rapidly detect bacterial DNA, especially N meningitis.
Faster than culture, right?
Much faster, yeah.
Oh.
Imaging like CT or MRI might be considered, but usually only in specific circumstances, like if you suspect raised intracranial pressure or an abscess. It's not usually a first-line step that should delay everything else.
Okay. Any specifics on the LP itself?
The notes stress it should be done without delay unless there are clear signs of raised intracranial pressure, things like a deteriorating consciousness level, specific focal neurology, or papilledema, which could make the procedure risky.
Right, risk of cunning.
Exactly. The CSF sample itself is sent for several analyses. Looking at the number and type of white blood cells, WCC, doing a gram stain to look for bacteria directly under the microscope, checking glucose and protein levels, which are typically altered in bacterial infection, measuring lactate, sending it for culture to actually grow the bacteria, and doing PCR as well.
Lots of tests on that one sample.
It's precious stuff.
Huh.
And the notes wisely add that early CSF can sometimes look normal or near normal. So if symptoms persist or worsen, you might need to repeat the tests. Don't be falsely reassured by a single early normal LP if the clinical picture screams meningitis.
Good point. What about investigations specifically for that really worrying combination of a petechial rash and fever in a child under 16? Is there a specific workup?
Yes, the notes list specific tests for this high suspicion scenario. A full blood count, FBC, CRP, C-reactive protein, that inflammation marker, a coagulation screen to check for clotting problems like DIC, blood culture, and definitely PCR for N meningitis on the blood.
Okay. And there's a few other investigations too, kind of depending on the situation.
Yeah, depending on the clinical picture, you might do other things. Renal function tests are important. A full coagulation profile if you really suspect DIC, that's disseminated intravascular coagulation, a severe clotting issue. Maybe a chest x-ray if there's concern for a lung abscess spreading. Sending urine, nasopharyngeal swabs, even stool samples for culture or virology if you're considering other causes.
Right.
CT scans are usually reserved for specific adverse features or if you suspect an underlying cause like an abscess or complication. They also briefly mention tests for specific, less common causes, like serum cryptococcal antigen for fungal meningitis or syphilis serology if that's clinically indicated.
So potentially a lot of tests, but the absolutely critical message, the note they keep hammering home is, investigations must never delay starting treatment if you have high suspicion.
Absolutely. Treat first, ask questions later, well, investigate later perhaps. LP is the gold standard for confirmation, but treatment comes first.
Precisely. Which brings us neatly to management, focusing on the approach outlined in these UK-based notes. What are the immediate steps?
Immediate hospitalization, that's non-negotiable. Get them in.
Okay.
And immediate antibiotic therapy is the next critical step. Alongside that, supportive care, like managing fluids and pain relief, starts right away too. And isolation precautions are important to prevent spread.
Right. And the initial antibiotic choice depends on age, before you know the exact bug.
Yes, exactly. For babies under 3 months old, the recommendation is IV amoxicillin, or ampicillin is an alternative, plus IV cefotaxime. That covers the common neonatal bugs like GBS and Listeria.
Okay, Amax plus cefotaxime for the little ones.
hmm For anyone 3 months and older, the initial broad-spectrum choice is usually IV cefotaxime or IV ceftriaxone.
Okay. What about steroids, like dexamethasone? Is that used?
Good question. The notes say to consider dexamethasone in specific cases, but it depends on the confirmed pathogen and the patient's age. Crucially, it's explicitly not recommended for children younger than 3 months. That's a really key point to remember for exams.
Got it. No dexamethasone under 3 months. Supportive care sounds like it could be quite extensive.
Oh, it is, because bacterial meningitis can cause major systemic problems. You need to treat shock aggressively, often with colloid fluids initially. Cerebral monitoring, watching for signs of raised intracranial pressure is vital. Mechanical ventilation might be necessary if the child is critically unwell and can't protect their airway or breathe adequately.
Right.
And you also need to manage any metabolic disturbances like electrolyte imbalances or circulatory problems very carefully.
And there's a public health element to management too, isn't there?
Hugely important. Bacterial meningitis, particularly meningococcal disease, is a notifiable disease. Public health teams need to be informed immediately. They then trace close contacts, family, nursery contacts, etc., and antibiotic prophylaxis is given to those contacts to prevent them from getting ill and stop further spread.
And do the notes specify the prophylaxis?
Yes, they mention that ciprofloxacin is now generally preferred over rifampicin for prophylaxis in the UK.
Okay, Cipro for contacts.
Yeah.
The notes also give specific antibiotic regimens once the type of bacterial meningitis is actually confirmed by LP results.
They do, which is helpful. So for confirmed meningococcal meningitis and meningitis, it's typically IV ceftriaxone for at least 7 days.
7 days for meningococcus.
Yeah, for pneumococcal meningitis, S. pneumonia, in children 3 months and older, it's usually ceftriaxone for 14 days. For adults, it might need different combinations based on local antibiotic sensitivities. They list ceftriaxone, cefotaxime, maybe adding vancomycin or rifampicin, depending on resistance patterns.
Right, sensitivity matters more in adults sometimes. What about H. influenza type B Hib?
For children and young people 3 months and older, it's usually ceftriaxone again for 10 days, adjusting based on sensitivities if needed. For adults, also ceftriaxone or cefotaxime first line.
Okay, and Group B strep in babies, say between 7 and 90 days old.
For GBS, it's IV cefotaxime for at least 14 days, sometimes longer.
14 days GBS and listeriosis, particularly in those young babies under 3 months.
Right. Listeria needs different cover. For babies under 3 months, it's a combination. IV amoxicillin or ampicillin for a longer course, usually 21 days, plus gentamicin added in, often for the first part of the treatment.
Okay, Amex plus Gent for Listeria in neonates.
And for adults with Listeria meningitis, amoxicillin is the go-to, with cotrimoxazole often listed as an alternative, perhaps if they're penicillin allergic.
So the key takeaway for management seems to be rapid hospitalization, immediate broad-spectrum antibiotics based on age, aggressive supportive care, then tailoring the antibiotics once the bug is identified, plus don't forget managing the contacts.
Exactly. Promptness is just paramount across the board, which leads us, logically, to prognosis. What's the outlook? What did the notes say?
Well, the notes really stress, again, that early diagnosis and prompt appropriate treatment are the absolute biggest factors for a good outcome. It comes up time and time again.
And they hit us with that pretty stark statistic. Meningitis remains a leading cause of infection-related death, especially in children, even with modern medicine.
Yeah. The final prognosis depends on several things, though, right? It's not uniform.
No, definitely not. The specific pathogen involved is crucial. Some bugs are just inherently worse than others. The patient's age and their overall health status before they got sick play a big role. And critically, how severe their illness is when treatment actually starts.
Are there specific poor prognostic factors mentioned?
Yeah, things like severe neurological impairment at presentation, a very rapid onset of symptoms, certain clinical signs like prolonged shock or seizures, those tend to point towards a poorer prognosis.
Okay. And how does that compare to the prognosis for viral meningitis?
Much better, generally. The notes state that viral meningitis usually has an excellent prognosis. Most people recover fully. Though they do acknowledge that longer-term issues, like fatigue or headaches, are possible, even if they're less common or severe than with bacterial forms.
And vaccination obviously plays a huge preventative role, which therefore impacts the overall prognosis by just preventing cases from happening in the first place.
Absolutely. Prevention through vaccination programs, like the MenB vaccine, is always better than dealing with the potential outcomes of the actual disease.
Yeah. Speaking of outcomes, let's look at the complications. What are the potential issues, both sort of short-term during the illness and longer-term afterwards?
Okay, so immediate complications listed include really life-threatening conditions like septic shock, which we've mentioned, and cerebral edema, that's brain swelling. Also, septic arthritis, where the infection spreads to joints. Subdural effusions, fluid collections under the duramater layer, which the notes say are quite common in young children. SIADH, that's syndrome of inappropriate antidiuretic hormone secretion, which messes with sodium and water balance. And seizures during the acute illness are also common.
Okay, those are the acute ones. What about the more lasting issues, the delayed complications?
These are really significant and often permanent, unfortunately. Hearing loss is a major one. Deafness is a well-known complication. Cranial nerve dysfunction, leading to things like facial weakness or eye movement problems, paralysis or weakness of limbs. And that really sobering statistic the notes give, somewhere between 30 to 50% of survivors of bacterial meningitis end up with permanent neurological disabilities.
Wow, 30 to 50%. That statistic alone is just,
Yeah.
it's such a powerful reminder of why this is such a high-stakes condition.
Yeah.
And why prevention through vaccination and that rapid treatment we keep talking about is so vital.
Precisely. Reducing the incidence through vaccination directly reduces the number of people who might face these potentially devastating long-term consequences. It's that simple.
So we've really journeyed through the material here, haven't we? We've hit the definition that causes across different age groups, the specific risk factors for meningitis B, how it actually impacts the body, what else it might look like, how common it is, the crucial signs and symptoms to watch for, especially those early ones. The key investigations, how we manage it, including the antibiotics and all the supportive care, the potential outlook or prognosis, and sadly, the possible short and long-term complications.
Yeah, we've essentially taken that structured set of revision notes and sort of unpacked each segment, hopefully pulling out the key facts and the connections between them. Understanding each of these pieces is really essential for building that robust knowledge base you need for revision.
It really feels like we've given the listener a high-yield path through this incredibly important topic. As we wrap up this deep dive, here's a final thought for you to consider, based on everything we've unpacked today.
Okay.
Given the potential speed and severity of bacterial meningitis, particularly meningitis B, how does the strong emphasis in these notes on recognizing those sometimes subtle early signs and initiating immediate treatment before you even have definitive diagnosis via lumbar puncture? How does that highlight the inherent tension and that critical balance between clinical suspicion and diagnostic certainty in urgent pediatric care?
That's a great question. It really is something that sits right at the heart of managing these kinds of high acuity cases, that judgment call.
Absolutely. Well, we hope this deep dive has been a valuable addition to your revision toolkit. If you found this helpful for your MSRA revision, you might find more resources over at passthemsra.com.
And for those specifically looking for free resources and questions, do head over to freemsra.com as well.
Thanks so much for joining us for this deep dive.
Yeah, thanks for listening, and all the very best with your studies.